Welcome to our video on microvascular complications in diabetes, focusing primarily on nephropathy and retinopathy. Let's begin. First, we're going to discuss diabetic retinopathy. Diabetic retinopathy is the leading cause of blindness in adults in the U.S. Just like other microvascular complications, it is also a direct effect of hyperglycemia and exacerbated by hypertension. Chronic hyperglycemia is directly toxic to retinal endothelial cells, causing increased vascular permeability, aneurysms, and leakage. All this leads to chronic retinal hypoxia. In response to hypoxia, several growth factors such as vascular endothelial growth factor are released, causing neovascularization. However, these newly formed vessels are abnormally fragile and prone to rupture. It takes time to finally get to the point where these new fragile vessels are formed, and according to that, we divide diabetic retinopathy into two main stages, non-proliferative and proliferative. On fundoscopic exam, when we can appreciate signs of diabetic retinopathy in the absence of neovascularization, we define this as non-proliferative diabetic retinopathy. And in more advanced stages, where neovascularization can be appreciated on exam, we define this as proliferative diabetic retinopathy. Let's try to focus on the most important changes, which help us guide the treatment. In the non-proliferative stage of diabetic retinopathy, the retinal vascular damage leads to small outpouchings called retinal microaneurysms. Also, the bleeding from the capillaries gives rise to small hemorrhages called dot and blot hemorrhages. As the retinopathy progresses and ischemia develops, other severe signs can be detected. These include cotton wool spots, which are fluffy white areas of microinfarction, venous beading, and other intraretinal microvascular abnormalities. Next, in the stage of proliferative diabetic retinopathy, the idea is that new retinal vessels are formed due to hypoxia and the consequent release of growth factors. We may see vitreous or preretinal hemorrhages because of the fragility of the new vessels. The subsequent fibrosis at the sites of hemorrhages can pull on the retina and lead to tractional retinal detachment. Please note that at this severe stage, the disease is vision-threatening, and therefore the best management is to avoid getting to this point. Finally, clinically significant macular edema, or CSME for short, can develop at any stage of diabetic retinopathy. This is often termed DME for diabetic macular edema. What's important to know is that when edema involves the macula, visual disturbances occur. In fact, this macular edema is the most common cause of blindness in diabetes. Let's first have a look at this fundoscopic image of a normal retina for comparison. Here we can see the optic disc from where normal vessels are emerging. We can also see the macula in this image. We cannot appreciate any abnormal vessel outpouchings or hemorrhagic or exudative areas in this image. Now let's look at this fundoscopic image showing some abnormalities that we talked about. We can see here the round, small microaneurysms scattered around the vessels and multiple dot and blot hemorrhages, which are slightly larger in size. It's not important to be able to differentiate between the two as they both indicate mild non-proliferative retinopathy. This image shows a more severe form of non-proliferative diabetic retinopathy. Here, in addition to the dot and blot hemorrhages and hard exudates, we can see these small white fluffy areas called cotton wool spots. These form when microinfarcts lead to the leakage of axoplasm from the dead nerve cells, and this indicates that the retina is now suffering from ischemia. Here's an image showing proliferative diabetic retinopathy. Note the formation of new vessels around these areas. The new vessels form an abnormal network, lacking the typical bifurcation pattern of normal vessels. Also visible are these multiple hemorrhages. Here's a fundoscopic image of diabetic macular edema. Hopefully we can appreciate the collection of fluid around the macular area right here. Let's quickly go through the symptoms a patient experiences in this condition. The majority of patients are asymptomatic, especially in the non-proliferative stage. In more advanced stages, or when the macula is involved, symptoms such as floaters, blurred vision, and visual distortion may occur. If a vitreous hemorrhage or retinal detachment were to occur, then the patient may experience a sudden vision loss. Lastly, the patient may complain of reduced vision if the macula is involved. Let's discuss the management of diabetic retinopathy. In order to prevent diabetic retinopathy from developing, blood pressure control and glycemic control is important. Additionally, an annual dilated eye exam, preferably by an ophthalmologist, is recommended as this will help detect diabetic retinopathy at the earliest stages. Mild non-proliferative stage does not require specific retinal therapy, and the only indicated treatment is further emphasis on blood pressure and glycemic control. However, to prevent neovascularization, anti-VEGF therapy or focal photocoagulation can be considered in severe non-proliferative diabetic retinopathy, or when macular edema develops. Once proliferative retinopathy is developed, pan-retinal photocoagulation is indicated to inhibit continued neovascularization and the associated complications such as hemorrhage. Let's do a quick review question. What is the role of anti-VEGF drugs in the management of diabetic retinopathy? These drugs inhibit the proliferation of new vessels. Recall that vascular endothelial growth factors are released as a response to retinal hypoxia and are primarily responsible for the formation of new vessels in the retina. Inhibiting the action of VEGF would therefore prevent this neovascularization and the subsequent vision-threatening complications such as retinal hemorrhage and detachment. This slide shows some other causes of vision disturbances in patients with diabetes. Cataracts are one important cause which occur because of the toxic osmotic effect of chronic hyperglycemia on the lens. Other causes are glaucoma, which occurs when neovascularization in advanced diabetic retinopathy involves the iris and obstructs the trabecular meshwork, and retinal artery occlusion due to thromboembolism. Let's finish up with a question to reinforce this information. A 60-year-old man presents to the clinic with progressively deteriorating vision in both eyes. He was diagnosed with diabetes mellitus 15 years ago. His medications are metformin, liraglutide, and simvastatin. He says he sometimes forgets to take his medications. His last ophthalmologic exam was 3 years ago, which showed no signs of retinopathy. Blood pressure is 125/75. Ophthalmologic exam shows bilateral lens opacities, and lower limb examination shows loss of vibratory and pressure sensation, diminished ankle reflexes, intact pulses with no ulcers or deformities. Labs show hemoglobin A1C of 8.1, urinary albumin to creatinine ratio of 130. In addition to cataract surgery and diabetic foot care, what additional drug would be beneficial in this patient? A. Propranolol, B. Lisinopril, C. Exenatide, or D. No additional drug needed. So it's a 60-year-old male who developed progressively deteriorating vision in both eyes and has a known cause of diabetes for 15 years. He's taking metformin, liraglutide, and simvastatin, but not fully compliant with his medications. And we know non-compliant patients who fail to maintain their hemoglobin A1C, as in this patient who has a A1C of 8.1, are at risk of developing microvascular complications. Moving on, his last ophthalmologic exam 3 years ago had been normal and did not show signs of retinopathy. However, at this time, his cataracts make it difficult to visualize his retina, and so we don't know whether he has also developed diabetic retinopathy or not. On exam, blood pressure is normal. Eyes are showing bilateral lens opacities, indicating the patient has developed bilateral cataracts, likely due to his poor glycemic control. Lower limb examination shows pulses are intact and he's not developed any ulcers or deformities. However, he does have signs of peripheral neuropathy, pointing toward poor glycemic control, and while this patient has not yet developed the diabetic foot syndrome, he's at risk of developing it in the future because of his peripheral neuropathy. In addition, this patient has developed moderately increased microalbuminuria, as shown by his urinary albumin to creatinine ratio of 130. So how could we go about managing this patient? Counseling for compliance with medications is indicated here, as is focusing on achieving the target hemoglobin A1C of 7.5%. So the patient will need to be started on additional hypoglycemic therapy such as insulin to avoid progression of his diabetic nephropathy and peripheral neuropathy. He also needs referral to an ophthalmologist for cataract surgery. Note that the patient is due for an ophthalmologic exam, which can be performed after cataract removal. He also needs specialized diabetic foot care. However, the question posed to us is what additional drug is recommended in this patient? And the correct answer is B, lisinopril. Recall from our section on diabetic nephropathy that moderately increased microalbuminuria is an independent indication for starting ACE inhibitors, even in those without hypertension, as in this patient with an optimal blood pressure. Now let's discuss why other options are wrong. A is wrong because there is no indication of a beta blocker in this patient. In fact, non-selective beta blockers such as propranolol are associated with increased weight gain and poor glycemic control and should be avoided in diabetic patients if possible. C is wrong because the patient is already taking a glucagon-like peptide analog, and prescribing another one from the same class such as exenatide would not be a good idea. The patient should be started on insulin or an oral hypoglycemic agent from a different class. D is wrong because this patient clearly has uncontrolled hyperglycemia and diabetic nephropathy and cannot be sent without additional interventions. And this concludes our section.